BK virus is a polyomavirus which is extremely host dependent. So it is very difficult to actually give an antiviral because most of the BK virus replication is based on the host machinery. So we cannot really have antiviral to treat BK. But whereas in cytomegalovirus, it is a luxury to have. We are going to discuss about which antiviral is better. So it is a little bit different. We are a little bit more comfortable treating cytomegalovirus compared to BK virus. But again, cytomegalovirus is called as transplant troll. So till the time the cytomegalovirus is reactivated, you are all very happy. Everything is going well. Once you see a cytomegalovirus in the blood, then it is a little bit irritating. Most of the time, sometimes we really don't know what exactly to do. We do some things based on whatever evidence which is there, whatever guidelines are suggesting. But we all know that sometimes the questions are a little uncomfortable. So we will try to kind of address those questions as well in this next 30-40 minutes. But I want to tell you that don't take any take-home messages from here and don't quote me bedside saying that Dr. Praveen has told me to stop immunosuppression or increase immunosuppression, right? So cytomegalovirus is a DNA virus with a big genome. So it has a lot of immune evasive strategies. If you compare RNA virus with a DNA virus, RNA virus is a small genome, cannot evade immunity, and basically the pathogenesis of RNA virus will depend upon the mutagenicity of RNA virus. So it tends to mutate because it cannot evade immunity. At the same time, the RNA coding is not even if there is an error in RNA coding, it will not get corrected like DNA virus. So the mutations tend to accumulate, but then when you have a good neutralizing antibody, it can be neutralized. So neutralizing antibodies are very effective in RNA viruses, whereas DNA viruses like cytomegalovirus or EBV, for that matter, hepatitis B, they can stay inside the cell for a long time. They can make a latent infection, evading all the intracellular, intranuclear immune strategies and stay there for life. So once you have a cytomegalovirus in the virus in your body, it is there. So in India, the advantage or disadvantage, I don't know, but more than 95% of the people carry CMV virus. So when you are transplanting a patient with a ESRD, end-stage renal disease, most of the times the pattern we see is donor will be CMV serology positive as well as recipient will be CMV serology positive. But where in Western countries, you see the CMV prevalence is less, somewhere around 50%. So 25% of the people can be donor positive and recipient negative, which is kind of a very high risk of CMV reactivation. So our discussion is more in positive recipients because we'll very rarely see a donor positive recipient negative state in India. So before really going into the topic proper, I would like to quiz our ID residents here, Dr. Anjali, Swati Kiran, and nephrology residents as well. So which of the following immunosuppressant is associated with the least risk of CMV infection? Quickly, sirolimus, okay. Easy, high risk of CMV is associated with serological status. D plus R minus. Identify the false statements. Preemptive treatment is associated with high CMV disease. CMV viremia is associated with high mortality. A negative CMV blood or plasma CMV will rule out CMV disease. Or CMV is associated with increased risk of PCP and aspergillus infection. More than one answer can be right. A negative CMV blood or plasma CMV will not rule out CMV disease. Okay. We'll come back to these questions at the end again. Identify the false statement. Little bit you have to know about these mutations. So can you just take a guess? Okay. Which one? Sorry. Anyway, so we'll go ahead with our session at this point of time. So I will be discussing this with a brief introduction, diagnosis of CMV. We'll discuss about this debate of preemptive with prophylactic treatment. We'll also discuss about the measuring cell-mediated immunity to guide the CMV prophylaxis. We'll also discuss briefly about antivirals and what is refractory resistant disease. And we'll discuss about mini dose prophylaxis, which most of the centers in India do, but there is a lot of discussion on it as well. The guidelines do not endorse mini dose prophylaxis, but we will really look into the literature. What does it say? And we'll also discuss about a little bit about the duration, right? So as we already discussed, the D plus R minus serological status is associated with higher risk, but most of the times we see intermediate risk with D plus and R plus status. Among the solid organ transplantation, if you are doing a transplants like kidney or intestine, which are immunologically very active and you have to really give a very high dose of immunosuppression to prevent rejection, the risk of CMV is quite high when compared to heart, kidney or liver, which are a little bit lower risk compared to lung. So in lung transplantation, the duration of CMV prophylaxis is quite long. Usually in kidney transplant, we decide on 3 to 6 months based on the recipient status. But in lung transplant, we usually give for a 1 year of immunosuppression. Then again, we will also discuss about how to assess the net state of immunosuppression. The answer is we don't know how to assess. Probably at the last lecture of this session, we will have some idea about it. And interestingly, mTOR inhibitors, which are like sirolimus, there are more than 10 meta-analysis now that mTOR inhibitors are relatively associated with less risk of CMV disease. Are we using it in the bedside? Are we switching the antimetabolite to mTOR inhibitor because someone is having CMV disease? No. So the literature is still gray, but what I want to tell you is any immunosuppression is immunosuppression. So even mTOR inhibitors will increase the risk of CMV, but when you compare it with an antimetabolites, probably the risk of CMV is less, right? So this is one of the very interesting things. If you go through all the guidelines, it will be very black and white. Do you have rejection or do you have CMV? So if you have CMV, treat CMV, and if you have rejection, treat rejection. Because of the immunosuppression you give for rejection, there could be CMV reactivation. This is how the discussion is. But more interesting discussions are done outside MM7 in the coffee shop with Shankar Prasad sir. So you have a patient with CMV reactivation, and also this patient is having rejection. You don't know what has come first, whether it is CMV, because CMV itself can stimulate NF-kappa beta pathways, which will cause inflammation. And CMV will cause steroid resistance. So if someone is on steroid, if there is a CMV reactivation, steroids will act through glucocorticoid receptors, alpha and beta. Alpha is most important. CMV inhibits that translocation of glucocorticoid receptor alpha to the nucleus. So if you are giving 40 mg steroid, patient is doing okay. Now there is CMV, there will be resistance to steroids. So once the CMV is reactivated, it can actually push the patient to rejection. And vice versa is also true. And this data is more clear in something like inflammatory bowel disease or steroid refractory GVHD in oncology. So if CMV basically stays in macrophages, endothelial cells, and epithelial cells, the moment there is some inflammation, there will be reactivation of CMV. That is the reason why you see critically ill patients, you do a CMV viral load in the blood, there will be some blip of CMV virus. That is because the macrophages are proliferating. So if you look into the literature of inflammatory bowel disease, many of these patients who have CMV along with IBD, the people still give infliximab. Infliximab is something which will inhibit the proliferation of macrophages, and they saw that the people have done better. Even active CMV, they have given doses of infliximab, and they have done better. So it is also possible that the patient had rejection now. Because of the rejection, you are seeing a blip of CMV. So the approach to your patient will be very different. So as an ID physician, whenever we get consult, we say that it is CMV reactivation, so immunity must be very low. You decrease the immunosuppression. Then nephrologist will be like, okay, so patient had basically recently kidney transplant because he's going to die. Now you're telling to stop immunosuppression. ID physicians will be very aggressive, stop everything. So nephrologists are like, okay, but there is rejection. So they will be in other side because we have to protect the kidney. So probably we cannot decrease the immunosuppression that much, and let us just give antivirals and see. But the reality is something in between, and we have to navigate through it, right? So you have to, first important question to answer is whether the rejection has started first or whether you are seeing CMV reactivation first. If you are seeing CMV reactivation first, probably patient is in a net state of immunosuppression. So your approach will depend upon that. But if you are seeing rejection, then there is a CMV reactivation, the approach will be a little bit different. At this point of time, can I say that probably we can stop anti-metabolite and switch it to sirolimus or mTOR inhibitor? For example, there is a patient with rejection with CMV reactivation. You are treating CMV. We all agree in treating CMV. We are also agreeing on stopping anti-metabolites because those are the things which are associated with very high risk of CMV viremia, whereas tacrolimus has little bit of intrinsic activity against viruses and steroids are little bit neutral. That's the reason why you give 1 mg per kg steroids for so many rheumatological patients, and you don't really worry about whether the CMV is going to get reactivated in those patients or not, right? So we'll stop MMF. We will increase the steroids a little bit if there is a rejection because there is CMV is causing steroid tolerance. We will maintain the tacrolimus. But if you really don't want to stop MMF, can we switch that to sirolimus is another question, which is not answered, but is an interesting strategy. The problem with mTOR inhibitors is they will delay the healing. And most of the times when we are seeing CMV, we are seeing CMV colitis or CMV pneumonitis. So it is possible that there is a CMV ulcer in the gut and you started an mTOR inhibitor that led to a perforation of bowel because it will prevent the healing. So the ulcers might not heal. But these are all theoretical concerns. We really don't know what we have to do in this. Second important thing about CMV is most of the trials you see, initial trials, when we are comparing one antiviral with another antiviral, the outcome was like, what is the percentage of CMV disease? And we are saying that newer antivirals are as good, for example, in prophylactic versus preventive strategy, whether there is a difference in CMV disease. But then people have also seen whether there is difference in CMV viremia. Obviously, in prophylactic strategy, it will be less compared to preventive strategy, because in preventive strategy, only after viremia you are, irrespective of whether they have developed CMV disease or not, had a poor outcomes in the terms of overall mortality or in the terms of overall graft function. Even in HSCT patients, the overall mortality was high if there is a CMV reactivation, because CMV is not immunologically naive. It will actually change everything. It might cause steroid resistance. Now you have a CMV, you have decreased the immunosuppression that can, so you have increased the steroids, and there is a CMV infection, ultimately increasing the risk of subsequent fungal infections. And the treatment for CMV is something like valganciclovir, which will cause cytopenias. And there is cytopenias, you are stopping MMF anyway. Then you are discussing about whether to continue the co-tremoxyl prophylaxis or not. The moment you stop co-tremoxyl prophylaxis, there are n number of infections that can come now, like nocardia, toxoplasmosis, or PCP, and many other. Right? So this is the complex situation. These are the indirect effects of CMV. So once you have CMV viremia, overall, if you look at this patient, the outcomes are going to be a little bit poorer than if the patient had no CMV viremia. So let us jump into the diagnosis of CMV. We all know that CMV viremia or DNemia is when you detect a CMV DNA in the blood. But what if the patient is having diarrhea? So diarrhea in a transplant patient could be because of a number of reasons. There are many parasitic infections, strongyloidosis, cryptosporidium, mysospora, cystoisospora, giardia, norovirus, and could be because of CMV, could be because of drugs like celiceptin, tacrolimus. So patient had a diarrhea, you are getting some blood CMV which is positive. So is it CMV colitis, or patient is having diarrhea and CMV is negative in the blood? Does it rule out CMV colitis? Similarly, in CMV pneumonia, there is a lung patch, patient is having cough, blood is showing some CMV, but is it CMV pneumonitis or is it some other pneumonitis? Or if the blood is negative, can you rule out a possibility of CMV pneumonitis? These are the very difficult questions to answer. So let us look into the gastrointestinal aspect. So if someone is having, you are suspecting CMV colitis, you can do a blood PCR, you can do an endoscopy, upper GI and lower GI endoscopy to look for any ulcers, and you can biopsy from there. You can run a PCR, you can do a IHC, or you can look for intranuclear inclusions in the biopsy sample, and you can also send it for viral cultures. Viral cultures are not practical, but most sensitive are viral cultures. So you have done a biopsy in a case of CMV colitis, and you are not able to find intranuclear inclusions. That doesn't rule out CMV colitis, because as you can see in this study, approximately 25% patients are viral culture positive but not showing intranuclear inclusion. So that means that just because the biopsy is negative, you cannot rule out CMV colitis as well. So how do we approach? Probably if we have any soft, obviously we are going to assess the patient clinically to know whether this patient is actually at risk of CMV or not. But at the same time, if you have something like blood viral load, this more than this is little bit more towards a possibility of end organ disease. So I'll be more careful in this patient. There are some studies where they have shown that if your blood viral load is more than 10 power 4, little bit be worried about a possibility of CMV colitis. So what I'm trying to tell you is, so you have a patient with suspected CMV colitis. A negative blood PCR is not going to rule out CMV colitis. You have to go and do a biopsy. But if your patient's blood PCR is positive, but you have done a biopsy and it is not suggestive of CMV, that will not rule out CMV colitis as well. Especially if you have a viral load of more than 10,000, be very careful. Think probably it could be CMV colitis which you have missed. Probably want to do a rebiopsy, or probably want to treat that patient as CMV colitis. Similarly, in CMV pneumonitis, the challenges are very, very similar. And the extra challenges, most of the times, it's very difficult to do a lung biopsy compared to gut biopsy, especially in the setting of CMV where you'll have cytopenias, thrombocytopenia. Many of the centers do bronchoscopy even in the presence of thrombocytopenia, but again, there is some hesitance to do even bronchoscopy, leave the biopsy part apart. So when you're looking at lung, again, if you do a bronchoscopy and BAL, the presence of CMV viral load in BAL will not confirm anything. And absence of PCR, CMV PCR in blood, negative CMV PCR in blood also will not rule in or rule out anything. Here, probably if you are seeing a BAL CMV viral load of more than 10,000, and if you don't have any other explanation for pneumonitis, patient is symptomatic, probably that is the time when you should probably consider CMV pneumonitis. Obviously, doing a biopsy and doing looking for intranuclear inclusions is gold standard, but that is most of the times more common than not. It is not possible in the clinical setting, right? So we'll move to the prophylactics versus preemptive strategy. What is this whole thing about prophylaxis and preemptive? We call it as PET strategy for the preemptive strategy. So in preventive strategy, what you do CMV viral load every week, monitor for any CMV reactivation. If there is CMV reactivation, you treat the patient till the CMV is negative, and then you follow up. In prophylactic strategy, we give CMV prophylaxis for all the patients. Now, the problem with the preemptive strategies, you have to make sure that the patient is coming every week, and you have to make sure that the sample is sent to the same lab, because if there is a variation between different labs, even though there is a standardization, you have to make sure that it is done in either blood or plasma, not once in blood, not once in plasma, and once weekly you have to do. And then the moment there is some blip, there is different thresholds to actually start preemptive treatment. So that threshold is not very well defined. But if you are thinking the patient is at very high risk of CMV, usually we take it as around 200. If a little bit low risk of CMV, probably 500 is a good threshold. But these are all very institutional based. And that is how you do preemptive. What is the advantage? Probably you are looking at 20% of people who never required CMV prophylaxis, and you can avoid valganciclovir in these patients. Very good. But 80% of the times you have to start antiviral. That is the problem. Second issue is, once you are giving preemptive treatment, you are kind of allowing a little bit of CMV replication. The idea is if you allow that, probably there will be a immunity which will develop to the CMV. So you can kind of avoid a late CMV reactivation. That is, once you stop prophylaxis, then in next 6 months, there is some risk of CMV, but probably that won't happen with the preemptive strategy. Are there any good studies in liver, in kidney transplant patients? No. There is one good RCT in liver transplant patient, but that also comes with some limitations. What is the problem with prophylactic strategy? Prophylactic strategy will prevent CMV reactivation, okay, most of the times. So if you are preventing CMV reactivation, you are actually avoiding all the indirect effects which you are attributing to CMV reactivation. But at the same time, because you are giving prophylaxis continuously, there could be late reactivation of CMV. Once you stop the prophylaxis, in next 6 months, there could be a CMV viremia or CMV disease. So you cannot prevent a late CMV disease. The another very interesting, very common problem is the side effects of the drugs. So we do have a lot of antiviral options right now. We have newer antivirals like letermovir for the prophylaxis. But the thing is, if someone buys other kidney, you can donate that to buy letermovir. It is that costly. So we are left with valganciclovir. We are most of the centers in India are following the valganciclovir prophylactic strategy. The cost is an issue. The side effects of valganciclovir are an issue. So once you have a valgan causing cytopenias, eventually you have to drop on the doses of Celiceb, like MMF, and which can lead to rejection again. So the if you are having a valganciclovir induced cytopenias, then there is a problem. So people have come with any interesting strategy. Let us decrease the side effects of valganciclovir. How are you going to do that? Decreasing the dose. Okay. So decrease the side effects. Let us probably, if you are giving lower dose of valganciclovir, there will be subclinical reactivation of CMV that might provide a immunity which will prevent a delayed activation of CMV. Very good. And it is actually cheap if you are giving 450 OD, half the dose of what is it. This is called mini dose prophylaxis. And this is very controversial, but personally, I feel it is very good. So I will tell you what are the reasons for that. So, so I have mentioned about one study in the liver transplant patients where they have found that the CMV disease at the end of 1 year is lower in preemptive strategy. But if you look at this Kaplan-Meier analysis, you can see that the mortality is higher in preemptive strategy. So obviously, preemptive strategy people will have a higher CMV viremia that can lead to mortality. This was not mentioned anywhere in the manuscript. It is there in the supplementary file. And this is one of the secondary outcome, but somehow in the main manuscript, you will not look at this results of the secondary outcome. So I understand that preemptive strategy is interesting. One K-pop is a trial which is going on in kidney transplant patients. We have to see the results of that. But in our setting, probably prophylactic strategy. and probably a mini dose prophylaxis. So one of the criticism for mini dose prophylaxis, if you are giving a valganciclovir at lower dose, eventually you might have a CMV which is resistant to valganciclovir, and when there is a resistant valganciclovir CMV reactivation, it is associated with higher mortality, right? So, but why not say same thing with the letermovir? Letermovir is a newer antiviral with a very low threshold to develop resistance. So, does it going to, like, if you are giving letermovir, probably it will also lead to resistance to letermovir and subsequently higher risk of CMV disease. But however, the study which has been done with the letermovir in transplant patients has not shown significant resistance to letermovir. But interesting thing is, they have compared letermovir with the 900 mg of valganciclovir, that is the routine dose. And in the 900 mg of valganciclovir, approximately 10 to 15% actually developed resistance to valganciclovir. So despite giving 900 mg dose, there is a resistance to valganciclovir. So this is one of the argument which can be against mini dose prophylaxis. So why not just look at the literature of mini dose prophylaxis? And but before that, one of the most important or difficult issue is immediate transplant time. So if you have transplanted the kidneys, and some of the patients will have delayed graft function. Now the urine output day one, day two is 3-4 liters, and creatinine is not settled down yet. So how are you going to dose the valganciclovir? It's very difficult. Just because urine output is good, you cannot say that GFR is good. Urine output could be good because of the bad tubular reabsorption, which can happen after the recovery of ATN or ATA. So dosing in this peri-transplant period is very tricky, but usually the approach is keep it at lower doses, because there are at least few studies, even if you delay the CMV prophylaxis by a week or 10, it is not associated with higher CMV reactivation or CMV viremia or CMV disease. So you kind of can actually wait till the day 7 till the things settle. But if you want to give upfront prophylaxis, it is okay to keep the valganciclovir at lower set rather than to the other side, where you might have developed cytopenias, then you have to deal with reducing antimetabolites, which will definitely increase the risk of rejection, right? So there is a systematic review of this mini dose prophylaxis at least 4 studies, and it is shown that it is associated with decreased CMV disease. Again, all these studies are not big RCTs. The quality of evidence is not great, but this is interesting that this effect is consistent. So when you are using mini dose prophylaxis versus routine dose prophylaxis, you are seeing less CMV disease. This is unexpected. Less CMV disease. One of the reason could be is that you are not probably stopping antivirals, because you have to stop antivirals because of side effects. So it's a good strategy. What about leukopenia risk? It is significantly low, less than 7, like it is 70% decrease in leukopenia, decrease in overall rejection, because you don't have to stop antimetabolites, because that is cytopenias associated with valganciclovir. So I think low dose valganciclovir, which should be compared head to head with letermovir, and that will actually help in countries like us, where the cost of antivirals is very high. So low dose prophylaxis can be effective option, something in between prophylaxis and preventive, and something which we can give as a prophylaxis with low side effects and subsequently improving the outcomes, especially when you have a newer antivirals using which we can even treat resistant or refractory CMV infections if patient is affordable. Yeah. So this is one of the study, and in this study you can see that despite of 900 mg of valganciclovir, there are 12% who develop resistance. Now the question is, in kidney transplant patients, you usually have a single function kidney. The other kidney is already gone. So you have kept a new kidney. You are expecting an estimated GFR of 60, probably 120 by 260 or 70. For that, actually, if you look at the valganciclovir dose, it is half the normal. So so-called mini dose prophylaxis could be actually the right dose for patients with kidney disease. We follow Cockcroft-Goat formula. That is not for AK, that is not for a post-transplant setting. So there is a basic controversy in how we are measuring eGFR when we are dosing the valganciclovir. The other important thing is the decrease in valganciclovir blood levels and subsequent resistance might not be just related to the dose you are giving. There could be multiple genetic polymorphisms. For example, someone is having polymorphism P glycoproteins in the gut, where the drug is getting excreted in the gut. Whatever dose you are giving might get excreted. And there are many other ways, many other genetic polymorphisms which can actually reduce the valganciclovir. So how about giving mini dose valganciclovir, but monitoring drug levels? And if you are achieving good, worry about it, right? So that is one of the most interesting strategies. The common mistake which we do in our clinical practice is not advising how to take valganciclovir. So ID residents or nephro residents, how to take valganciclovir with food, without food, empty stomach. So it has to be given after a fatty meal. So the area under AUC of valganciclovir will increase by 1/3. So actually 900 mg valganciclovir without food is equal to 450 mg valganciclovir after a fatty meal. So that is the most common thing which we do wrong, and that should be taken care of, right? So what about the duration of prophylaxis? Shall we give it for 200 days or 100 days? In a high risk patients, we do advise for a 200 days, but most of the times we have a R plus recipient where 300 days is enough. That could be followed by probably monitoring of CMV viremia, especially in patients who are at a higher immunosuppressed state, or probably you can just stop it and follow up the patient. Yeah. So now the problem is with the delayed CMV reactivation. So when you're stopping a prophylaxis, obviously there is a risk of CMV reactivation in the next couple of months. How are we going to know who is this patient who is going to get reactivated? Can we measure the immunity to CMV to know whether this patient is going to get reactivated or not is an important question. And this question is, we are trying to answer this question for a long time, not we, the people are trying to answer this question. There are a variety of strategies. One of the strategies is getting the CMV quantiferon because it is an easier thing to do. And it has a binary outcomes like quantiferon of more than 0.2 is protective, less than 0.2 is not protective. So if you have a protective cell-mediated immunity against CMV, probably are more comfortable stopping prophylaxis at that point of time. So you have given 3 months of prophylaxis, you got a CMV quantiferon, it is negative. Probably you don't want to stop CMV prophylaxis now and you want to reassess after some time. So this is one strategy. In R plus recipients, there are a lot of studies and it is showing to be promising. Not in a R negative patient. So if the patient is D plus R minus, the negative CMV quantiferon might not help you. One more patient is if patient is having severe lymphopenia, this test will come as indeterminate. So before sending quantiferon, look at the lymphocytes. So what we can do in our setting is at least look at absolute lymphocyte count before stopping CMV prophylaxis. So patient has completed 3 months of CMV prophylaxis, no complications. Now we are looking at the patient whom you want to kind of stop CMV prophylaxis, but the absolute lymphocyte count is less than 600. There is a higher risk of getting reactivation. So if it is more than 600, probably you are more comfortable in stopping CMV prophylaxis. This is something which we can easily do. And if the lymphocyte count is less than 600, that lymphopenic, probably the CMV quantiferon might not help also. So at least this is very interesting that we can look at absolute lymphocyte count before stopping the CMV prophylaxis. Let's move on to CMV treatment of CMV disease. We have a lot of antiviral. We will not really go into the details of all these antivirals. Valganciclovir, ganciclovir we use routinely. Effective. They eventually inhibit the DNA polymerase, so it is very effective in killing the virus. Whereas cidofovir also acts to the same mechanism, very effective, just like valganciclovir. The problem is cidofovir is associated with a lot of side effects, especially in kidney transplant patients. You don't want to have a drug which will really affect the kidney. It also affects the eye. It can lead to iridocyclitis. It can decrease the intraocular pressure and blindness. So you really want to monitor proteinuria and vision in the patients who are receiving cidofovir. Foscarnet, again, very effective drug, but very toxic as well. Approximately 30% of patients who are receiving Foscarnet will develop AKA, a lot of electrolyte imbalances, so much that people can develop arrhythmias and neurotoxicity as well. Very costly. I think rarely we have, I think we haven't used Foscarnet for a long time now because most of the times affordability is issue. Now there are two other antivirals which acts by a little bit different mechanism. Letermovir is a ternase complex inhibitor. So once the DNA is formed, the chopping of DNA and egress of the CMV is prevented by letermovir and maribavir respectively. So the problem is, these antivirals are not acting at the level of DNA polymerase, so not very cidal. So when you are looking at a patient with letermovir prophylaxis, if you see here, because you are measuring DNA and letermovir is not inhibiting the formation of DNA. So if you're looking at the peripheral blood for CMV, there could be some viremia, for example, 500 international units. In letermovir, maybe okay. That's because the DNA formation you have not inhibited. That is one of the reasons why if you are using something like maribavir for the treatment of refractory CMV, because it is not inhibiting actually the DNA virus replication, the risk of secondary reactivation once you stop maribavir will be theoretically high, which we'll show in the subsequent slides. Yeah. So how will you define a refractory CMV. You have a patient with CMV colitis, for example. You have started on ganciclovir, and patient did have some CMV viremia which you can monitor. So after 2 weeks, you had done a repeat blood CMV, and if there is a no increase in CMV viremia or at least 1 log reduction is what you expect. If it is not there, probably you are looking at something like refractory or resistant disease. Resistant disease is resistance to antivirals. Refractory disease could be because of the immune status of the patient. So patient's immunity is unable to control the CMV replication. So it keeps on replicating, right? So that is the reason why you have to say it as refractory and resistance disease. Because you cannot always say it is the failure of antivirals which is causing the persistent CMV. This is how we define. But again, if you look at this trial, it's Victor trial, which has compared oral valganciclovir with IV ganciclovir. In that, you can actually see the patients who had actually viral load above 50,000. It is taking a long time for the viral load to come down. So it is at the 2 weeks, if you are not seeing 1 log reduction, but if the patient is improving, wait for some more time, especially if they have viral load of more than 10,000. You can wait for a week or two and again repeat and see. No low dose treatment for CMV disease. It's only for prophylaxis, which we have discussed. So just because we are saying 450 OD for prophylaxis, don't make 900 OD for treatment. That will definitely lead to CMV resistance. So there are a lot of mutations which will cause antiviral resistance. For ganciclovir, you need a 3 kinase step. One of the kinases from viral kinase, UL97 is required for the activation of ganciclovir to the active form of ganciclovir, which is effective against CMV. So UL97 mutations will cause ganciclovir resistance, but not CIDR4 and foscarnet. And UL54 mutations can cause resistance to everything. Most of the times, the ganciclovir and CIDR4 mutations area is in the same region, which we call as exonuclease and region 5. So if you're having ganciclovir resistance, because of UL54 mutations, there will be usually a associated CIDR4 resistance. Whereas you can have ganciclovir and CIDR4 resistance without foscarnet resistance and vice versa. So there will be a complicated situation where you have a UL97 mutation causing ganciclovir resistance, and then a mutation is UL54, which is causing foscarnet resistance. So in this situation, it is possible that patient is having resistance to ganciclovir and foscarnet, but is still susceptible to CIDR4. So any combination is possible. Basically, what I'm trying to tell is you cannot say that because ganciclovir resistance, it is CIDR4 resistance or anything like that. Okay. What about newer antivirals? So maribavir inhibits UL97. So UL97 is a viral kinase which is helping ganciclovir to become an active form. But maribavir is inhibiting UL97, that is causing decrease in the viral load, right? So you cannot combine ganciclovir with maribavir because one needs UL97 for the activation. Can someone online? There is some noise. Can you mute yourself? Thank you. Yeah. So all the combinations are possible, especially maribavir and letermovir are very soft drugs. If you keep giving them, there is a high risk of resistance. Even in refractory diseases, maribavir, eventually people have accumulated mutations to maribavir. One interesting thing is there are some mutations in UL97 region which can cause resistance to like ganciclovir, but they can make it hyper susceptible to maribavir. Similarly, what we see in HIV, like M460V, which is there, probably a good MCQ for quiz. So you are giving ganciclovir and patient develop M64V and patient is resistant to ganciclovir. Now you give maribavir, patient will respond more than better because the virus is hyper susceptible. Okay, so this is one study, solicited study, which we keep quoting about maribavir. In this study, you can see that in patients with refractory CMV disease, compared to whatever other treatment you have in the combination of other antivirals, maribavir has definitely done well. But once you stop maribavir, in next few months, you can see only less than 50% of the patients are CMV viremia negative. They are relapsed again. So it's a very soft drug. So once you, in this study, they have kind of stopped maribavir at 8 weeks without giving any secondary prophylaxis. But if you are treating a refractory and relapsed disease, probably the ideal strategy will be give maribavir, clear the viremia, and put the patient on secondary prophylaxis, probably with letermovir if you have a lot of money, right? So maribavir and letermovir are kind of drugs which are a little bit soft. drugs. And what about secondary prophylaxis? Do we need to treat all CMV disease or viremia once you have treated, once the blood is negative or patient has improved? Shall we stop the antivirals there, or shall we continue secondary prophylaxis for some more time? This is not very well answered. Many other times people don't use secondary prophylaxis. I try to give secondary prophylaxis all the time, but the real answer will be if you can measure the immunity, if you think that the patient can take care of whatever CMV reactivation is there, probably that is the time you want to stop secondary prophylaxis. So measuring cell-mediated immunity in deciding secondary prophylaxis can also be helpful. If you look at this study, again, this study, the conclusion is secondary prophylaxis is not helpful to prevent subsequent CMV disease. But if you look at the mortality again, patients prophylaxis had lesser mortality. Again, the CMV viremia comes into play. A CMV viremia is not just CMV viremia. It can affect a lot of things later on, right? So before concluding, we will quiz again. So what is the answer now? Oh, I expected a louder response. What about this is easy. And what about this? Preemptive treatment is associated with high CMV disease. Is it true? No. Preemptive treatment, not in kidney transplant, of course. In liver transplant, at least preemptive treatment is associated with lesser incidence of CMV disease. But obviously, preemptive treatment will have higher CMV viremia. So that is also false. And negative blood and CMV will not rule out a CMV disease. Approximately in 50% of the cases, that's a very big number. So someone is having diarrhea, you have done blood PCR negative, you haven't ruled out CMV, not at all. And now you can answer this question. UL97 mutations are associated with CD4 resistance, true or false? False. UL97 mutations and UL54 mutations in DNA pyrophosphate region, that is region 5, will cause phosphornate and ganciclovir resistance, but not CD4 resistance. True. Complicated. There are region 2 and 4 mutations are associated with resistance to both CD4 and ganciclovir, right? And there are no mutations causing cross resistance to maribavir and ganciclovir. This is also wrong. There could be cross resistance to maribavir and CD4. So it is not like patient is maribavir and ganciclovir. It's not like a patient didn't respond to ganciclovir. He will be obviously susceptible to maribavir. Most of the times it will be, but there are some mutations which can cause cross resistance to both also. So to conclude, CMV is a transplant role. Even CMV viremia has a lot of indirect side effects, which will have implications in overall graft function and overall survival as well. Measuring cell-mediated immunity in CMV might help. Probably measuring immunity is a big area. So our genome has approximately 5% of endogenous retroviruses. Dr.Tirlangi is one of them. It looks like our all presentations are finally leading to Dr.Tirlangi. So it is one of, probably if you see the reactivation of endogenous retrovirus, probably you can measure immunity. Not very clear right now, but we'll see more about it later in the day. Mini dose prophylaxis is not obsolete. So the guidelines which were recently concluded, no statement about mini dose prophylaxis, but it's a very interesting strategy. The problem is the evidence is not very strong enough to make it into guidelines, but there are a lot of literature which is accumulating. And it is really a option to look for LMICs where the cost of antivirals is quite high. Letemov is for prophylaxis, not for the treatment, because if in high viral load,